of disability and injury related to untreated depression. So, of course, while depression is really prevalent everywhere, it affects immigrants even more because we have added risk factors. And when you say, well, what are our added risk factors? Well, there's a separation from our family. People have been displaced. They are away from their family, they're away from their friends, away from the network of support they had. There's a language barrier that causes stress at any level, whether it's in school or at work. Financial stress, and most people, when we immigrate somewhere, you have a lot of high hopes, and sometimes those hopes don't come through. So the unmet expectation is also a big cause that we as immigrants face. And now, increasingly, now that we've been here long enough and we have the next generation, the cultural difference and generational gap is another big contribution to what triggers or what can contribute to someone developing depression. So one might ask, well, what are the most common, what are the symptoms that are recognized for depression? So clinically, by the psychiatric community, it's defined as sadness or feeling hopeless, loss of interest, low energy, sleep and appetite changes, trouble concentrating. Those are the general, and at worst stage, it's thoughts of suicide, thoughts of self-harm. While these are the medical definition of depression, this isn't how it often presents. Depression actually often presents with symptoms, normal physical symptoms, and that could be a headache that never goes away, stomach pain that we can't find any treatment for, pelvic pain, back pain, or always being fatigued, never, even after sleeping for 12 hours, not feeling rested. So the most common presenting symptoms are actually physical, and which is why it goes undiagnosed for such a long time, because most people think this is a physical and not an emotional combination. So again, some of the most common physical is chronic fatigue, unexplained pain, headaches, either overeating or undereating. Is this better? Okay. Sounds like me, okay. So I'm just going to quickly go back to what are the presenting symptoms, because those are the most important. Again, that's chronic fatigue, unexplained pain, headaches, stomach pain, back pain, pelvic pain, that no matter what you do, doesn't go away. Many times as a primary care physician, when patients come with stomach pain that doesn't go, I have sent patients to have CT scans, MRIs, they've had colonoscopies, endoscopies, nothing. All the results come back negative, and yet the person doesn't feel any better. They're still feeling those pain, but the reason those pain are not relieved by everything else we've done is because we haven't addressed the underlying condition, which is the depression. And sometimes people will say, I'm just so irritable. I'm more irritable than usual. I get angry easily. I cry for no reason. So that is a little bit closer to the emotion, but or sleep disturbance, I can't sleep, or I wake up really early in the morning, early morning waking is a sign, or waking up 4 or 5 times through the night is a sign. But unfortunately, those are also that people could say, well, I'm tired because I didn't sleep well. So all of them kind of gets tangled up. And it makes it harder for someone to think they actually have a condition they should seek assistance for. So again, the question is like, well, who is at risk for this? Obviously, everyone is at risk. We just said over 280 million people are affected worldwide, so everyone is affected. But some of the risk factors that increase are childhood or adult trauma. And Lord knows, most Eritreans have had more than their share of losses and trauma. So that puts us at risk. Stressful life events, having to flee your country and immigrate qualifies. Losses, those are some of the risk factors. Loss of parents, marital issues, not having enough support system when you are in a new place, economic hardships, and some genetics are related as far as what the risk factors are. So, well, if this is this common, why don't people ask for help? And the resistance to ask for help is not unique to us. I think most people, from no matter what culture they come from, the idea of seeking mental health, there is a stigma. They rather think they have this unexplained stomach pain or unexplained disease than to actually consider, well, maybe this is a mental issue. So I think that's part of the big problem is it's that denial and not wanting to be stigmatized, not wanting to be judged by others. And then the other one is because people look at it, they minimize it. We always say, well, I can handle this. I can figure this out. I'll take care of it myself. And sometimes people will, maybe it's just in my head, maybe there's nothing wrong with me. So, and there's a degree of embarrassment or language barrier in terms of being able to discuss it with someone. And some people also feel like, well, this is going to be too expensive. My insurance doesn't cover it. So, and some people actually don't realize there are so many medications available that can help. And those medications don't have to be a lifetime. They can be episodic. So not having that, these are all the reasons I think most often people don't seek help. But the one thing that I do want to make sure we're clear, all of us here, and we can share it with everyone, is depression is not a sign of weakness. Depression is not failure of it is truly a medical condition. It is not something it's just something that develops. And when it does, like everything else, like blood pressure, like diabetes, we need to get care. We need to seek consent. There's no, just like we had talked about earlier, you know, Askeret was talking about her son, and it was really moving because her fight made him who he is. Well, mental health is not all that different because when we don't talk about it, when we don't address it, bigger and more complicated issues come. I'm sure I'm not the only one that hear so many young Eritreans killing themselves. Suicide was not a common experience in our culture. It wasn't something that you heard of. At least when I was growing up, it was rare that you heard somebody kill themselves. Now it's becoming a common phenomenon, and it isn't limited to kids that got in trouble or it's an old, no, it's all kids, all youngsters, some of them doing very well for themselves in school, and by all accounts, these kids are doing fantastic, and yet they're found dead. Or they're dealing with all these demons that no one talks about, so then they try to self-medicate, whether it's with alcohol or drugs or what have you, and then there's an accidental overdose. And it's really sad when you see kids that I remember them being as toddlers, that I could find out that they had they died of overdose. All of this is because we're not addressing the issue. We're not letting them know that it's okay to need help. And it is okay for us to seek help and to also listen, not be judgmental, not. So it's becoming a really big problem. And again, it's a condition that needs to be addressed. So when someone does seek help, there are available options. There is talk therapy, and if someone is struggling and they don't want to consider medications, I know we all have reservations about drugs. There's talk therapy, and talk therapy is not a new concept for us as Eritreans, as community, because even though back home we don't have psychiatrists or therapists, but we have elders that, when someone has an issue, they will go to the elder woman or man in their community and address whatever the issues are, and those are how it was solved. I don't know how many of you are old enough to know or have heard the term amanite. People say amanite kede. This is a person who gives them comfort, who counsels them. Abat nafse kede. This is a person they go to, they talk when they have issues, the person who gives them guidance and how to move forward. So talk therapy here, we're in the US, we don't have amanit, we don't have abat nafsi, but we have trained professionals who could provide a similar service. And if you meet someone, it's not easy to find a good therapist, so I'll be the first one to admit. Just because you don't communicate with that person, just because you feel like, well, that person just doesn't get me, don't stop. Go look for someone else. There are plenty other therapists. You just have to find one that matches you. You have to find one that connects with you. And then the next thing is the medication. Some of these medications most of them are not habit forming. Most people, for their first episode of depression, actually, treatment of 6 to 9 months is sufficient to put them back on track. So it isn't necessarily something you have to be on for life. In some cases, sure, yeah, you need to stay on it. But in most cases, in the beginning, it's a short course. But even if you do have to be on it for life, there's no problem taking blood pressure for life, no problem taking diabetes medicine. So this should be no different. At least we shouldn't look at it any different. And the other optimal thing would be to combine talk therapy with medication. The combination of that also works very well. Then the third part is what's known as a lifestyle. Lifestyle meaning getting an exercise routine. Even if it's a 30-minute walk that you do every day, and that's yours. So that gives you time to think, gives you time to calm down, gives you time to reduce your anxiety. But also, exercise releases a hormone called endorphin. It's a happy hormone that our body actually naturally makes, but it's only released during exercise. So the exercise, in a way, is providing therapy. Making sure that you're sleeping around the same time and taking care of yourself, taking care of your body. Those are some of the ways that could be helpful. So another question is like, well, for these things, how could a doctor help you? Well, primary care doctors are very well suited for this because once you eliminate, well, this is not a migraine, this is not a brain tumor, or there's nothing wrong with the stomach, you work out through all of that and you come to the conclusion, and there are screening questions. And in that screening question, if you test positive, what they can do is refer you to a therapist, which is what we're talking about. They can start medication if necessary. They keep everything confidential, and this is the person that you can trust and you can see as often as you need to, because it's covered by the insurance, so it's not something cost-related that you have to worry about. So now, then the next step, probably by far the most important aspect of this, is how family and community can help. The best way family and community can help is actually, again, similar to what Asgera said. When you take them for training, that's just 30 minutes. It's the home. So family and community can help. So if you notice someone is having symptoms, ask them how they feel. Listen carefully. Don't make judgment. Learn about their condition. So make them feel heard. Acknowledge their feelings. You don't have to understand it. You just have to acknowledge it. And then encourage them to go see a doctor. It's like, well, you know, you've been feeling like this for 2-3 weeks. Maybe it's time to get someone to help you. Offer to go with them for support. So these are, in a way, and if it's someone, for example, a woman with young children and needs help, which I know Salam is going to talk about, offer to keep the children for her. Provide whatever support that is getting in the way of them needing help. So all of this, of course, is when it's built. But if you ever notice someone who is suffering, or you experience yourself, someone having suicidal thoughts, and most of the time people could it's hopelessness. Oh, what's the point of living? Then there are hotlines. That's all that they're dedicated to do. There are no questions asked, and these are all very important, and they're the same across the country. 988 is not specific to Dallas or California. You can call that any time, 24 hours, and there will be someone on the other side to help. But last but not least, I just want to go over the key take-home points, and those are the most important thing is depression is very common, it's very real, but it's also very treatable. It affects everyone, and it doesn't present as necessarily a mood. It's not like I feel bad or I feel sad. Most people actually come with pain, fatigue, and those type of things. There's no shame to ask for help, and your doctor in your community is your best resource. And thank you for your kind attention.
Hello. Hi everyone. Shumei Salam Gibrandaras Yebahal. Dr. Yenay Harrison Insek Hamamat Mahatsen. I am an obstetrician gynecologist and I work at the University of California, San Diego. The topic of my talk today is women's mental health. So we will be reviewing these common mental health challenges within the framework of the hormonal timeline, which means we'll be talking about issues that impact young girls, then young women, and then older postmenopausal women. So we'll start with understanding our hormones, biza'aba hormonat, then premenstrual dysphoric disorder, dysphoric then postpartum depression, and then perimenopausal and postmenopausal depression and anxiety. So in order to understand how these hormones work and how they impact the brain, you have to first understand where they come from. And so we're going to start with the menstrual cycle, also known as the period, also known as warhawitzagat. So hormones from the brain control the ovary. For the first 2 weeks of the month, the brain tells the ovary to make estrogen. Estrogen then works to prepare the egg in the ovary And estrogen also thickens the lining of the uterus to prepare for a pregnancy. Estrogen neti zir'in shifan mahatsanan yedalu. In the middle of the month, you have ovulation, so the egg is released. And then in the second half of the month, if there's no pregnancy, then the ovary makes progesterone. And progesterone's job is to shed the lining, and then you have a period. Progesterone So how do these hormones impact the brain? Well, that just described how the brain communicates to the ovary. How the ovary then communicates to the brain is in a lot of these very complex ways. And we have to think about the hormone like a key and the receptor like a lock. So when the key enters the lock, it opens the door to all of these functions that you see. So we have in the prefrontal cortex that manages your decision-making and self-recognition. The hippocampus is memory. The limbic system is your emotional identity. You have serotonin and dopamine pathways that regulate mood. The hypothalamus, stress. And you see how estrogen and progesterone receptors are all over the brain. Estrogen and progesterone. So we see that if the brain is used to having these elevated levels of estrogen and progesterone, whenever we experience a drop in the hormones, that's when you start to have symptoms. Dereja estrogen and progesterone, kuwarid kolo sagamata. So we'll start with premenstrual syndrome, or PMS, which I'm sure a lot of women have heard of this before. It's very common. It's about 85% of women and girls will experience a collection of mild physical and mental symptoms prior to the period. So you see in the graph here, the first half of the month, your estrogen is rising. The second half of the month, when estrogen is declining prior to the period, is when you start to have symptoms. It's the estrogen kagodel kolo melakatat yejumuru. So what are these symptoms? They tend to be mild. Sometimes you're a little irritable, some itawi, forgetfulness, menasat. But the treatment is, again, because these symptoms are mild, tend to be regular lifestyle things and time. So exercise, sleep, to make sure you're having good self-care. Now we'll get into premenstrual dysphoric disorder, or PMDD, which I think a lot of people have not heard of. It only affects about 3% of women. But this is when you have severe mental and emotional symptoms. And they occur because, as we saw on the last slide with the graph, when estrogen drops, the brain has that sensitivity, and then you get all of these strong symptoms. So it's not just unkat, it's kabit unkat. As you tell you, so you have these strong mood swings. Women will come to us and they say, I don't feel like myself, this is ruining my life. And we know that it's not regular depression and anxiety, because in the beginning of the month, they feel fine. Then before the period comes, that's when everything becomes severe. And they feel like a whole new person as soon as the period starts. So how do we treat this? Well, part of it's the lifestyle things that I just mentioned, but also therapy, can help. The kandi fosiyuntayu, birth control pills. So pills that have estrogen and progesterone in them, which is makavkalitansi kaminatat. So essentially, instead of you having the fluctuations in your body, by taking a pill every day, your body then experiences the same amount of hormones each day. And that's what typically resolves the symptoms. Now we'll get into postpartum. We're going to start with postpartum blues, which is essentially affecting pretty much everyone who's had a baby, and anyone here who's had a baby can probably relate to what I'm about to say. So you tend to have mild symptoms in the first 2 weeks after delivery. ምልክታት ድሕሪ ህርሲ ዝጀምር ኮይኑ ኣብ ውሽጢ ክልተ ሰሙን ግን ይሓልፍ እዩ። So we call this hormonat murat. And you see in this graph, during pregnancy, the hormones are rising. As soon as you have the baby, they plummet quickly. እቶም hormonat ድሕሪ ጥንሲ ብቆጠፍ ይነኪ. And it's that dramatic drop that causes the crying. It's very mild ጭንቀት. There can be some difficulty sleeping, ድኻም, fatigue, a little irritability. But the ቀንዲ ፈውሲ ጊዜ እዩ. So your body knows how to resolve this, and it improves with time. But you also need, of course, family support. ድጋፍ ስድራቤት, ዕረፍቲ is also very important. Now let's talk about postpartum depression. ድሕሪ ልብሲ ዝመጽእ ጭንቀት. So this affects about 15% of women, and it can impact you from the time you have your baby up until 12 months later after you've had the baby. And unfortunately, still half of women do not get a diagnosis. ፍርቂ ካብተን ድሕሪ ልብሲ ዝርከባ ጭንቀት ዘለወን ደቂ ኣንስትዮ ምርመራ ኣይገብራን እየን. That's a very high number. So what are these symptoms? Well, it's more than just the ድቃስ መጽገም, ሰምዒታዊ. Now we're having ከቢድ ጭንቀት. We have guilt. በደል ሰምዒት. What is that? Women will say to us, I feel so guilty, I'm not a good enough mom to my baby. My baby deserves a better mom than me. ተስፋ መቁረጥ. They feel hopeless. I will never be a good enough mom for my baby. ሸውሃት የለን. They don't want to eat anything. Loss of joy, hagos መጥፋት. So they don't want to smile and laugh at the things that they normally do. And then loss of interest in the baby. Up to ህፃን ትግደሰነት መጥፋት. And then also you can have thoughts of self-harm here as well. So when we're making the diagnosis of postpartum depression, it's ከቢድ symptom ምልክታት in addition to the length of time. So it's not just the postpartum blues, the first 2 weeks. This is ongoing. So it's after 1 month, 2 months, 3 months, it's ongoing symptoms. So how do we treat this? Well, ድጋፍ ስድራቤት is very important. You need family, you need ዕረፍቲ, you need exercise to get some sun. But ምኽሪ ምሃብ is so important. You need therapy to teach you the strategies to manage your symptoms. ጭንቀት መድኃኒት is also so important. Many women say, I can't live like this, I need help, but I'm afraid to take medicine because I'm breastfeeding. But we do know that medications can be safe with breastfeeding. The one that we prescribe all of the time is sertraline or Zoloft. This is the pill you take once a day. Also, women say, I don't want to be on medicine for the rest of my life. Well, just like we heard from Dr. Eliftai, you don't necessarily need to be on it forever. On average, postpartum depression is about 6 months. That means only you need the medhanit once a day. Like I said, there are other medications you can use if severe in the hospital as well. The last point I have here on all my slides, faith in this. So we as Eritrean people, we come from different faith backgrounds. But I always ask my patients here, do you have a faith system? Do you pray? I used to write on the papers, because tzolot medhanitu too. But we have to remember, when you're praying to God to help you get through a trial, a difficult, set of symptoms, how does He answer your prayer? He gives you the appointment to see the doctor. And then when you get the diagnosis and you say, I have this diagnosis, I don't know what to do. He answers your prayer by giving you the prescription for the medication or the session with the therapist. So it's very important. Yes. But also when God is answering that prayer, you need to be open to what He's telling you. And also, people don't have to know. People don't want to take medicine because they're afraid. What if people find out? No one has to know. I tell these women who come to me with postpartum depression, you don't have to tell your family if that's the thing that's keeping you from getting help. Yes, we encourage you to share with friends, share with at least your mom or your aunt, someone, maybe friends. But if at the end of the day you don't have a place to go, you have us, you have your therapist, you have your doctor, you have your nurse, and we can help you also. Okay, I'm briefly going to mention postpartum psychosis. This is very rare, so it only occurs in about 0.2%. But I did want to mention it. So what are the risk factors? Who is at risk for this? Typically, it's somebody who already has mental illness, like bipolar disorder, which we're going to hear about, or they've had this psychosis before. But essentially what can happen is within the first couple of weeks of the delivery, women can start to have very, very severe symptoms, hallucinations. That means you're seeing things that aren't there. Delusions, meaning you're believing something that isn't true. Extreme depression. Even thoughts, not just thoughts, sometimes actually they do harm themselves or harm the baby. Insomnia, it's not just like postpartum depression, they can't sleep. They don't sleep for days sometimes. Also paranoia. ሓደ ጊዜ ኣብ ኤርትራ ከለኹ I had ሓንቲ ጓል ምስ ሓረሰት. She came maybe ድሕሪ 2 ሰሙን. She had complete symptoms. She couldn't talk. She couldn't eat. She was aggressive with the family, with her baby. And even though the family came to us because they thought it was some ጥንቆላ ዓይነት ሕማም ገለ, they were still supportive and open. And after about a month of getting her on medications in the hospital, we were able to get her back to eating, talking, and being safe with her baby. Even here in the US, I had a patient last year who had signs of bipolar disorder in the pregnancy, and after she had her baby, she continued to have thoughts of killing her baby. She even was noticing she was getting angry with her other children. She was sometimes hitting them harder than she normally would be as spanked, but she's hitting them hard. And she would come to me crying and crying and crying because she knew that she had this psychosis and that she was going to hurt her children. In the end, we got her into the hospital and we were able to help her with Manhani. So I say all of that to say this is very serious. If ever you hear about something like this, you need to get to a hospital right away. Okay, lastly, we'll finish with menopausal symptoms. Now, we all hear these words, menopause, perimenopause, premenopause. What does it mean? So premenopause is essentially how it's again. So that's from puberty to perimenopause. Perimenopause is when, usually around age 45, the periods start changing to the last period. And then menopause is when you've gotten through 1 year without a period. So 40% of women during this time of life can have symptoms. That's a lot. And we know that especially our Eritrean women in the 40s and 50s, 60s, they're not necessarily coming to us to say that they're experiencing these symptoms. But this is a very high number. So what are these symptoms? Irritability, as we've been discussing, you can have ruminating thoughts, anxiety, low mood. Of course, everyone thinks quick to anger, loss of interest also is there as well. How do we diagnose this? Well, it's similar to depression and anxiety, but it occurs around the time when the periods start to change, and based on the age. That's how we know that it's associated with perimenopause and menopause. So how do we treat this? Well, of course, the same things: family support, exercise, healthy lifestyle. But something I wanted to highlight here is very important: self-care. Because we know in this age range, women are not doing this. The purpose of their life, if you ask them, is my kids, my husband, my home. But how many of them are actually asking themselves, if you're already dealing with the hormones changing, affecting your brain, if you don't take the time to think about what gives you joy, then these symptoms will only get worse and worse. So is it that you want to learn to read and write? So many of our women in this age range don't know how to read and write. Do you want to go back to school? Do you want to volunteer? Do you want to learn a new skill? Focusing on those self-care things are going to help you during this time. Also, managing your physical symptoms. If it's that you cannot sleep, because of this perimenopause and the hormones changing, then how could you have a positive mood when you wake up in the morning? So you have to get help for the physical symptoms you have. Is it the hot flashes? Is it the night sweats? So there are many treatments, not to go too much into just menopause. I could talk about that for hours. But hormone replacement therapy is an option if you don't have any specific risk factors for other health conditions. It can be safe. Hormone replacement therapy means taking estrogen and progesterone back into your body to help balance your mind, balance your brain, and some of the other physical symptoms. It can be a safe option. Don't say, oh, I don't want cancer, I'm not going to do it, but then suffer in silence. You can talk to your doctor to see if it's right for you. Also, ጭንቀት መድኃኒት is always there as well, your antidepressants, anti-anxiety medicine if it's severe. So my last slide is just resources. If you're looking for information, where do I learn more? www.menopause.org. That's easy to remember. You can learn a lot of evidence-based information, also for pregnancy and other gynecology topics. ACOG is the American College of OBGYNs. That's what we use on a daily basis. If you know someone who's suffering from postpartum depression, your friend, your sister, and you want to help them, but they're not wanting to help themselves, you can help them find a therapist. Even that is the difference of it. Help them get the resources they need. You can go to locator.apa.org and you can find the therapist near you. And then for the hotline I have here is specifically for women who you think are having thoughts of hurting themselves, postpartum, hurting their baby. 1-833-TLC-MAMA is a resource that we use as well. That's it. Thank you.
يقاطم سلازلو بزعبا mental health قبل زبل حسابات سلازمسه بوينا مجمريا ناي اوتيزم حجو خا بفلاي سنه عناوي سنه عمرو ناي اغوابز ناي مدرسه مسوتا عايزنا نقبل زلنا قدمي استزاربا دكتور اللتا كم primary care physician I'm sure بزح حسابات depression anxiety وكاله كنتات زلهم مسيوم أبزعد بس زلوا access to care na mental health مالتي بزحات سبات تزقوا حاجز primary care ብዙሕ antidepressants ወላ anti-anxiety medication ንሳቶም እዮም ዝዝዝዎ ስለዚ ኣገዳሲ እዩ ምስቲ ፕራይመሪ ኬር ዘለካ ርክብ እንታይ ዓይነት ሕቶታት ዓተት እንታይ ዓይነት ሓገዝ ትረክብ ኣገዳሲ እዩ ከምኡ ከዓ ደቂ ኣንስትዮ ዝሓልፍኦ ዝፃወርኦ ብዙሕ እዩ ምስኡ ተሓይዝካ ናይ ጥዕና ነገር ኣሎ ብዝተፈላለየ ዕድመ ዝመፅእ ኩነታት ስለ ዘሎ ብፍላይ ንዕኡ ኣተኲርና ከምዚ ግዜ ወሲድና ዶክተር ሰላም ገበረትልና ኣገዳሲ እዩ ሕቶታት እንተሎ ድሕሪኡ ንምልስ ኢና እሞ ኣነ ሓንቲ ወይ እንደዛሪበ ነይረይ child, adolescent and adult ናይ ቆልዑት ናይ መንእሰይ ናይ ዓበይቲ ሳይካያትሪስት ኮይነ ኣብ ሜሪላንድ ወፃኢ ዋሽንግተን ዲሲ ማለት እዩ ዳርጋ ን30 ዓመት ኣብ ፕራይቬት ፕራክቲስ ሰርሕ ኣለኹ ኣብ ህዝብና ብዙሕ ናይ ሜንታል ሄልት ኢሹስ ኣሎ ሓገዝ የድልየና እዩ ኩሉ ግዜ ሓበሬታ ዝብሎ ነዞም መንእሰይ ድሌትን ክእለትን ዘለኩም ኣብ ሜንታል ሄልት እንተኣቲኹም you will find it rewarding ስራሕ ኣሎ independent ክሰርሑ ትኽእሉ ኢኹም reasonable work life balance ኣለዎ ስለዚ ድሌት ክእለት ዘለኩም ከምኡ ከዓ ንደቅኹም ክተባዕግቦም ሓደራ በሉ እሞ as I said the presentation will be primarily on mental health related to adolescents and young adults and the reason for doing it is this is the stage in life a significant number of mental health issues do arise and it will be very critical to recognize them, to seek help and to address them and the ability to do that will definitely have a better long-term outcome and will minimize or mitigate the extent of the disruption and the distraction and the dysfunction that can be created in the individual's and the family's life. So if we have time, what I would like to go through is major depressive disorder, bipolar disorder, schizophrenia, suicidality or suicide in adolescents and young adults. I'm sure we all hear about, different unfortunate events happening among our youth or older people, and suicide, in my opinion, is a rather premature passing of any individual, and there may be cases that could have been prevented, granted somebody did seek help, did seek proper treatment and diagnosis. Very briefly, I'll talk about generational trauma. Dr. Elinta did talk about it briefly. I think the Eritrean community for decades has gone through traumas. We in our community don't talk about it, but it's very important to recognize it, to be educated. I don't think I'll do much justice to do it as just a topic in one of these presentations. Hopefully for future presentations, we may take the time and spend the whole presentation on generational trauma. Because whether we know it or we don't know it, I think a good number of us are impacted by it to an extent. If we do have very superficially, we'll talk about substance use disorder, and then finally about treatment modalities in psychiatry. As a psychiatrist, what I'm involved is primarily in pharmacotherapy. I have an extremely busy practice, so the way I can allocate my time to as many patients is by providing pharmacotherapy or a type of treatment that includes medications. So if we talk about adolescence, what is adolescence? Adolescence is that period of time where the onset of puberty means to show certain features of being a young adult. This is where a significant period where they start developing friendships, maybe some romance. They increasingly will be spending time outside of the homes. And it's a very important time to develop independence and responsibility. So this is a very important period for parents to instill a parenting style that is conducive to help the youth to grow, to develop, be independent, and have a very positive self-esteem. There are different types of parenting styles. I should have one style on that, but very briefly, there's a type of parenting that's called authoritative, which is a type of parenting that is warm, supportive, and it has clear expectations and responsibilities. So it's very much so collaborative between the parents and the child or the children. And this would develop and enhance positive outcomes with children, adolescents, and then young adults with positive self-esteem. There is another type of parenting. They sound similar, but they're different. It's called authoritarian, ወይ ብዝዓድና ፓድሬ ፓድሮን ይትበሃል ኣነ ዝበልክዎ ጥራሕ ይኹን ዝብል ፓረንቲንግ ማለት እዩ እዚ ፓረንቲንግ ከዓ warmth ወይ love ብዙሕ ዘየርኢ ኮይኑ እቲ expectations እቲ rules ግን very strict እዩ very rigid. So this type of parenting unfortunately doesn't help to develop self-esteem. እቲ ብዙሓት ደቅና ምናዳ ኣወዳት ንሪኦ ዕድሚኦም በፂሑ ወይ ሃይ ስኩል ክኣትዉ ከለዉ ወይ ሃይ ስኩል ወዲኦም ንኮሌጅ ክኸዱ ከለዉ ዝፃገሙ እዮም ይሽገሩ እዮም ምክንያቱም በቲ ዝግባእ ዕድመ ኣቺቭ ዘይገበርዎ ስኪላት ኣሎ እቲ ኢንዲፔንደንስ ነቲ ሪስፖንሲቢሊቲስ ኣይሕለፍናዮን ባዕሎም ብሓሳቦም ንክገብሩ ዲሲዥን ንክገብሩ problem solving skill ንክህልዎም ዕድል ኣይሃብናዮምን so ዕድል ገይሮም ወይ ዕድሚኦም በፂሑ ናብቲ ዝቕፅል ደረጃ ክሓልፉ ከለዉ ብዙሕ ይፃገሙ we call it failure to launch the time management organization ኣብኡታት ዝያዳ ከም ደቂ ተባዕትዮም ይፃገሙ ካብኡ ዝተፈለየ ካልእ ዓይነት parenting ኣሎ one is permissive ዝኾነ parenting እቶም ቆልዑት ጥላዮም ክገብሩ ብዙሕ routine ከይሃለዎም ጥላዮም they just run the show ካልእ ከዓ not engage ወይ ከዓ neglectful ዝበሃል parenting ኣሎ እዚ ኩሉ ሳዕቤን ኣለዉ ማለት እዩ so እንዳዓበዩ ክኸዱ ከለዉ እዞም ቆልዑት ናቶም independence assert ክገብሩ ክደልዩ ከለዉ ወለዲ ከዓ ቁሩብ ነቲ control ምግዳፍ ይጥቀሙ Parents have a hard time letting go. So this creates a significant of conflict between parents and children. So besides the style, there is the culture, there is the belief system, and then kali ነገራቱ ንህሉ ግን ሕና ክንዓቢ ከለና እቲ ተዓባብያና ዝተፈለዩ ኣብ ዓድና ሕጂ ንሕና ኣብ ዝመፂና ንደቅና ከምኡ ክንዕብዮም ኢና ንደሊ እንታይ ደኾይና ኢና ዘይከምዚና ዓቢና ንብል The truth be said, our parents did not know any better. But as ዝፈልጥዎ እዮም ገይሮም ንሕና ግን we should know better. ስለዚ ከምኣ ስለዝነበረት ንሕና ከዓ ከማይ ኢና ክንገብር ኢልና እንድሕር ቀፂልና እያ እዚ ክንገብሮ ንኽእል ከይገበርና ክንተርፍ ንኽእል ኢና ማለት እዩ እዚ ገሊኡ ፀገማት ንሱ እዩ ሕጂ ንሕና ኣብ ክንዲ ደቅና ኣብቲ ንስታቶም ዘለዎ ንኸይድ ንስታቶም ናብቲ ንሕና ዘለዎ ክመፅእ expect ንገብሮም which is almost impossible. ለዚህ አዋቅሮብ ፀገማት ኣለው ንሪኦ ኢና እቲ ኣጋጣሚ ክርከብ ከለኹ ምስቶም ስድራታት ንሰርሕ ከምኡ ሓገዝ ክንገብር ንፍትን ኢና ሕጂ ቁሩብ እዚ ኮቪድ ምስ መፅአ ኣብ መንእሰይ there was a major concern about mental health in the adolescents following the COVID era ማለት እዩ It was a mental health crisis. When the kids were isolated, when they were not interacting and socializing with their friends, their peers, and what have you, they started showing signs and symptoms of some distress. So the Centers for Disease Control, CDC, did a survey. The survey anonymous, online, 110 questionnaires for about 7,700 high school students who were in 9th grade to 12th grade. In the first 6 months of 2021 is when they sent the surveys, and then they published the surveys. So the CDC reported that around 37% of high school students experienced mental health issues during the pandemic or COVID. About 44% of them experienced persistent sadness or hopelessness. About 20% of them had some thoughts of suicide, and actually about 10%, which is 1 out of 10 adolescents actually did endorse that they've attempted suicide. In Tayongero, there's no detail, but nevertheless, they did report that. So this was the survey, but looking at actual mental health in adolescents, diagnosable condition about 25% or 1 out of 4 adolescents do have a condition that is diagnosable. If we look at anxiety, when we say anxiety, it's excessive worrying, fear, panic attack, social anxiety, PTSD, obsessive compulsive disorder. The rate increases with age. At 12 years of age, about 8% are diagnosable with anxiety disorder. By the time they turn 15, the rate increases to 18%. So sometimes we don't recognize it. كمولد مثلا دكنا نايتشنكت تصقم كهلوم دخل إلنا بزو حين حسين أنت إذا صدقنا على أنت إذا شجرنا قرالهم إلنا نقمتنا. And some of it is a failure of understanding what they go through. It is system نايبة مرتي وعلات محزنة حركنة زحالفو. I think sometimes صبوا غيرنا ينردو أنينا ولا bullying يغون alienation ويمقلاي or marginalization كم تنورو اللغة بقى بستفراغ يخون سلزغل نحن مصدقنا صبوا ركب صبوا communication علينا سمعنا تسمعنا يوم زنبرنا نقرات تهلو سلزغل أقداسي لقمت مسؤول عايزة ADHD زبها نقراله which is attention deficit hyperactivity disorder زها والعود أبتمرتي أمسوعال أب direction مهتال سجم سجماتيو depending on the severity كاب لسنا تمالا preschool زلوا الجمهور لو لكن استيو بزو hyperactive impulsive لزيكونا early diagnosed كونانيان منادات قرعة نحر بتمرتي يقول بفلتات بخلت نفع وينفعت تقينا they compensate for it so they keep going until they're challenged so it might not be evident until later in life. مقابلنا هنا بزو حيز revenue eating disorder علو ثم من إستي مقبي زلوين ويسحبا نفسهم زلوا مرة عيا positive كيكونه هون كله eating disorder بحال anorexia nervosa, binge eating, bulimia زبالة الجوالا دكنا خلون تزيد لهم ثم حافتهم يوم ثم مهارتهم يوم كم عينة أجمعات زلوا كلوا كل يوم. سلذي نزونتات أنت فريتنا يوم كما يجيرون عاتهم كإمباكت جورو ما يفكت جورو حتى زمن تمسيو أو أن التحابرهم نخلينا. This is a controversial issue, but increasingly there are gender-related issues that come up. زها دكنا مماهرتهم نصمزم مهارو العد كم زتات عينة issue deals قبوش لزلو. I think providing support and understanding would be very important. أنتوي بزح زعبا depression دكتور إلتات زاربات فلوس لزلا بزح جزية يحلفني in درجة 4 خميسي or about 40% of adults who have depression have the onset of depression when they were young. And the younger the onset of the depression, the more severe it is and the more impactful it is and the more difficult it is to treat. لذي أقدم كانت depression مفلات treat مكبار I think will have major benefits down the road. What are the risk factors for depression or any other mental health issues? And the way I'm working so genetic factors play a major role. In my opinion, بزناتي ريا ويا نفولتون نخون ويا نقبلون نخون ويا نكحدون نخون mental health issue أبصدروز دلوس ليه بنستوي يلا We all have. How close we're related to them is a different issue. Lezi نعرف فريقنا تقبلنا يو the family history in time مقانو the genetic predisposition تفريقنا يو تقمنا يمبر حاسيناني عندنا عن توي زعبات symptoms of depression تزاريبون يرو the major symptom of depression is a persistent depressed mood, okay, with some physical symptoms like a decline in appetite, sleep, weight, lack of interest, and enjoyment. It's not only being depressed, but it's causing an impairment in one's level of functionality and enjoyment. Depressed, مخان تراح زي كونس مسوز مسا صعبينات كا نسبي زي كتسنا مالتي. ስለዚህ ኣብ አንቶይ ወንክን ዛረበሉ ሰንሒናና ስክሪኒንግ ዝበሃል ነገር ኣሎ ከም ቆልዑት ቶም መንእሰይ ናብ ሓካይም ከዱ ከለዉ ስፔሲፊክሊ ነቲ ኩነታት ንክፈልጡ ወይ ንክርድኡ ምንታት ዝሓቱ ሕቶታት ኣሎ ደቂ 12 እስካብ ደቂ 18 ዓመት ከለዉ ንበይኖም ወሲዶም ዝሓትዎም ሕቶታት ኣሎ ገሊኡ ሕቶታት ሕጂ ቅድሚ ሕጂ ዶ قال الحمى حسابات غيركم نفسهم تدفوا لهم وحاسبكم نيركم زبر حتى المسكين لازم نسمع لنا قال يوسف لان تايبوا لكن انا حاسبهم مو زي نبروا حساب ابو حنقولهم انتوا ولا مالو بعد زربال اذا لك حيكون نقول كزربا يمدن فسيم كحاسب كاو زي نبركا حساب تقوي مستد لازم لك حساب مساء مالتك لذي هيركا اوسي دا مزراب منهم حماق يقولون سلزغم وسمعنا ولدن دلنا I food that's par for the course. This is very set diagnosis sometimes toys welco a primary care setting is around Zumsana Dr. Liltala, around Dr. Awan Labs pediatrician. I'm sure they see their share of depression and anxiety. So the treatment and the way psychotherapy the Bahini. Psychotherapy in Thai. Or about the Abraham Thai. Psychotherapy ማለት ከይድካ ብዛዕባ ምስመን ተባሂስካ ምስመን ተጋጭካ ዝሓለፈ ሰሙን ከመይ ሓሊፉ ወይ ከይድካ ኮምፕሌን ትገብረሉ ቦታ ኣይኮነ ሳይኮቴራፒ ምስ ቴራፒስት እንድሕር ፅቡቅ ርክብ ጌርካ እንድሕር ቴራፒስት ክርዳእካ ጀሚሩ the therapist should understand the way you're thinking. So therapy is supposed to change the way you think. If there's too much negativity, then you have to recognize it and you have to change the way you think. Therapy is about changing behavior. If you are self-destructive, self-sabotage, therapy is about making changes. Therapy is about recognizing patterns of behavior and gaining insights. There are lifestyle changes and exercise. If he was not controlled, control exercise due, nutrition due, lifestyle due, the class due. What I tell you, the governor they have negatively impact the governor. I don't want to use the word toxic. It's our choice to distance ourselves. It's our choice to choose and have a relationship we want. So, control can go wrong, nagarat control nuboro. Depression now bipolar disorder. Bipolar disorder is a form of a mood disorder. Depression is a mood disorder, and bipolar disorder is also a mood disorder. Depression is a very largely common disorder. Bipolar disorder is less frequent. So what does bipolar disorder mean? So manic depressive, it's known for having extreme mood swings. It's a سمعت بزح اللواوت بزح الكياير أبوش تحدى معلتي حنسب هذا سبتعم حقوز high energy كوينو مثلا بيساني أخا depressed code. Not necessarily changing in the same day, but the premise is there is a severe mood swing. So what it means, the definition of bipolar disorder is a distinct period and persistent, elevated, expansive, or irritable mood associated with some behaviors. Manic chonkolosa or elated chonkolo muskuz bahariat hallo. دكا سايد اليوم مني تزربا معاتي تزربا عقلتي فهم يوم تزاربوا يتصعبوا ما يتخلني هذه their mind is so disorganized that they're jumping from one topic to the other. So bipolar disorder type 1 type 2 زبالالو it's a prevalence rate of America in the past within a year close to 3% زغون سبات bipolar هزوميو. Bipolar disorder is very tricky. It has a very high rate of suicide. It causes major disruptions. There is significant denial. I could balonium from sabat bipolar alone. The bipolar alone sabat usually against krahbuz mesu depressed on holoy. So depressed alone slezmosu net depression in a treatment go. And unfortunately, the depression treatment go halana. It's in her own forcing, you have to do. It's the antidepressants, Namenia is the though. The suicide rate is about 15 to 20% in bipolar disorder. Schizophrenia is about maybe the most severe psychiatric disorder, although the prevalence rate is about 1%. Schizophrenia is a form of thought disorder. It's also known about of compromised reality testing. It is how one zone of reality مقبل يصدقوا ماله مالتي. So it's a form of thought disorder. There are different symptoms. And Dr. Salam Galisat Tonera, delusions, fixed false beliefs. زاربوا أنا مسايا أنا مسأولة استفادير كبالني. متعدد delusion fixed beliefs اللي ماله hallucination سالت hallucination كا زي اللي نقدر مسمع وزي اللي نقدر مرأي مالتيو paranoia هذا paranoia house عبون اللو they're coming after me the government is coming after me the FBI and so زبال symptoms مالتيو the onset of schizophrenia is younger. That's why it's important to recognize it between the ages of 15 to 25 for boys, a little bit late. Ejo Adam, أنا سمعكم له أستاذ at University of حميمو دملي شوفا. The problem wasn't going away to college, even though it's stressful on you. The major reason is better admit it's not seen normality. And there are external factors that contribute to schizophrenia. Haman, once again, genetics plays a big role, and then life events, trauma, stress, losses can also contribute to that. Okay, جغرب في حالة قوة تزارب كلها يحلف من ذا زعبا suicidality زبل أوروب نزارب مالتي نسمعنا بستفر على بوتاتات من سيكم زخوينو وتحالفو زبا زرباتات. Suicide is the second leading cause of death among adolescents. The first reason the youth or the young lose their lives is because of accidents. And Harinayo, more young people die of suicide than cancer, heart disease, or other medical conditions together. So the Kanustio more attempt to go around, and the Katabahatio more complete to go away. So now suicide can be kalanasi protective factors. Wala the suicide happen kay gabur zikala and the ainet factorat alon telna. Some say if they have effective coping skills, problem-solving skills, and they have adaptive behaviors, they are able to work through whatever crisis or problem they have. A failure to do so, unfortunately, increases their risk. And if they have a reason for living, if they have a loving family, a supportive community, that would be a reason for them to live. And a strong sense of cultural identity, relatedness, knowing that they're important to a community of people, that people care for them, will help them to overcome any of those dark moments they may have. And access to care, whether it's a pediatrician or a mental health professional, or even the ability to access a coach, the ability to access a priest, an imam, All those things are very protective factors. Then there are also risk factors. Risk factors below. Previous suicide attempt is a risk. A history of depression, mental illness, especially those that are not diagnosed, underdiagnosed, or not treated. Serious medical illnesses, legal problems, family history of suicide, lack of social support, and all this will increase it. So I'm going to be concluding my speech. They're giving me signs that my time is up. So if there are any questions, we get into the question and answers. But thank you for all your attention.
Thank you for our speakers. We'll have time for question and answer from the group. And we're also handing out surveys to complete and to give us feedback on what topics you want our group to address in the future. I see your hand raised already.
Okay, thank you. بدعم يغني كلهم Dr. Salam, I enjoyed your Tigrinya. You really tried hard. I'm proud of you. Yeah, a big clap for you. I enjoyed listening to you. Because all of you touched depression. This is much needed topic for our community and the Eritrean. It's a depression, especially in young adults and youth. It is big, it's huge. My biggest question, and I know so many parents have the same feeling and the same question because I speak to a lot of them. Some of the moms come talk to me, and I know it's a very sensitive topic, especially as a young adult. How do you help them? How do you open the conversation? Because most of the time they're isolated, okay? Ziala, Abai problem, lazy generation, telephone. This is their friend, their parent, their advisor, whatever. How do you break that cycle? What do we do? How do you approach them? What do you tell them without hurting, I don't know, their feeling or not to ask wrong questions? So Buzuhat parents, this is the problem they have. They want to help their kids, and then like you talked about suicide. By the time you try to help them, it's already too late. And we've seen so many kids lose their life. And like Dr. Eritrea, you said, it's so sad because in our generation, we had so many other outlets. It's really hard to get into their brain and to understand their problem. So how do you help our society? Because we don't get this opportunity. We need this kind of discussions to help all these problems that we're facing in regards to mental health. Thank you.
Thank you. So I think, of course, Dr. Mahtema has a far more experience in psychiatry, so he probably have other answers. But as far as from a primary care stand or just in general, the best thing to do is when you notice a change in behavior. And instead of waiting until they've been in their room locked for 7 days, for weeks, as you're seeing the changes, spend time with one-on-one, not at the dinner table saying, what's wrong with you today? You're moody or whatever, but actually, hey, let's you and I have a date today. Take them out and let them talk to you. You can say, well, I've noticed this difference. What's going on? Do you have a new friend? Just very simple, non-judgmental, like you really want to know, not you're not accusing them that they've done something. And then they're one-on-one. They have your attention. And it may take them a little while to open. Just sit there. Eventually, they will start to speak. Eventually, they will tell you enough. And don't push. So it's like, okay. And so you make these a habit where you're seeing them more often. And then you offer, okay, well, maybe I don't know how to help you, but I can find someone. Would you be open to that? They have to feel a sense of control. You don't just drag them to the doctor's office. You ask them, if I took you somewhere, do you think you would go? So allowing them to have a power, some type of autonomy, some type of, they have a say-so in their life. And giving them that attention is the way you crack the, and once they know they trust you, and you've established that, it will, it's like an onion. You peel one layer at a time. The first month might just be one layer. Then, so that's how I advise my patients.
Well, let me see if I can add to what Dr. Eritrea said. My approach is, keeping the children engaged, having routines, maintaining the routines. Is it a meal time? Is it activity time? Is it a homework time? Just stay engaged, maintain the level of involvement you have. The second thing is, one of the problems our children have in coming and talking to us is they think we are judgmental, we're closed, we're not open, and they don't see a point. Why bother? So I said it earlier, instead of us expecting them to come to where we are, if we go to where our children are, if we have a better understanding, if we leave some of our value systems on the side, and approach them, and there's what's called an empathic listening, where you do talk to them. I mean, we love them, we care for them, there's no question about it, but it's also how we come across, okay? So that's what's important, and being open to talk about them, And there are so many learning experience, moments in life. Anything that happens in their lives or our lives every other day is an opportunity to talk. So if we're open, I think the change actually should start from the parents, in my opinion. And it's not only parents, but then you could have two parents who have opposing views, or who may be approaching the disciplining or the parenting from an opposite point. So what it creates is conflict, and the kids know who to go for what reason, and not only will they take advantage, but they will expand and make the problem within the family worse. So, in my opinion, sometimes the children are symptoms of the problem within the family. So as much as we talk about the kids, then we also have to, have an open and better conversations among ourselves. If we are on the phone ourselves, browsing or doing whatever we do on the phone, we're modeling a behavior. So we can't go back to them and say, hey, get off the phone, when we're not doing the same thing. So we need to live by example. We need to mean what we say. We need to be very consistent and reliable. And we should be the ones that need to be open sometimes, so they can come to us and talk to us.
أبدأ أوروبا كوسلا مدقام عي فتوني جنزا دكتور ما حتى مدبنا بدعمي عقدها سيتيا إتي نجبرو نحنا ندق أنا تخرجوا ولا نبلون راح يكون سني تخرجوا ولا عصرت حبوشت عصر شوعة عمد كوينهم أمينهم خا قد بحجوا ولا حنتي تبغى ركب دينا كله خنقرها خطبيهم قبول عيكونن انت هذا برجلها التورتي نأشتو خلوه كنترعوا لنا إتي closeness إتي مخببان ولا لأني نحنا خوي نقبروا قلعوا خلنا خوي عارنا خوي نتزارنا يوم كلنا individual سبينا أبتعدوا خاني تسحبنا بزوفنا داري نتهم قلعوا انتهي قبروا ولا خردهم انتهي ناتمروا ما لهم تليفون لهم كمبيوتر لهم ماكينة لهم أنا فاهم زي عابوا لنا لأن أسوتنا تم تسمعهم بس يبقى اللي خدكم تقابل لنا دايما نقاس إذا تسمعوا ولا لو تسمعوا ولا لو يا نحنا الصورة هنا هو سمعنا كلام وخوني جين السادة كمان تسمعوا معاملة نتقبله كم يجري مو حق ذاك خمسين تبلن لها you feel frustrated how can I support you كم يجي متقبل إذا كل زار لنا إذا أنا كلا أكيد بلغاني أبونا دين أبغى whatever أبغى زاد لو كلنا بحاجة من أنكم فوقنا لنا دحر أنا خمس جبر بخوينا هسه أي خمس جبر عبايو خابز على خمس جبر بخونا ندخل على confusion خا create جبر له دلها كلنا تزارارينا اتفقتي تزيفوا هذا ما له حتى مسوينه خمس بخونا له الناس ني really open conversation كله دحر consistency دحر ديال أمم قول سمعين ثبت إن إحنا له maybe disagree with the brain هذا بالقوة هنا قدم يوم ما يكون كل دريا أقدم يوم نروح خبيت بلون خبيت باليوم ما يكون اللي بهال سنحزانوني شعوب مش هديو أقول وزي خيرات والعادة يبلو كمزن درنا يزيا كمزن أيام لاني كان عريالنا كلنا حنس أخوينا بحرمتنا the same message تهربنا يوم more trust اللوم تدري كوينو يتعوضوا لنا كان التليفون آخر لا دليل كم ما هذا بدنا دكتور ما هذا بدنا كما دحر نحن تليفون كما لنا كما جين مني اللي غفلت التليفون مني اللي جزء أدلو نحسبها من إحنا مش نهبهم كلنا كنهبهم كلنا كندشون كنقبر لنا أوكي أتراكم كله تليفون كمت اللوا وكل ساعات معلت يدو يفكر whatever it is سني أكيدنا خم جمرتها خنكونن مش مررنا كنا نحب تليفون كقوس لا يكونن خم جمرتو contract عينتي زين privilege زين حتى ما لا أخي ويدي ما لا أخا كنت بسدي أنا هاني كنزارب لنا.
Thank you. Do we have any other questions? I see. Okay, right here. We'll go right here.
Okay. This is a very important issue. Mental issue is very tough. What I was thinking was, like a good example during the COVID time, is there a hotline, a medical association hotline? I would rather see that, you know, if worst comes to worst, they can go and check on that or ask questions. Because, you know, the medical system here is kind of screwed up, especially for those who went through the healthcare system. The patient is a number. It's who you know, what questions you can ask. You have little bit information to what you are asking. So I would like to see a hotline for the, you know, for the medical association hotline healthcare, especially specific healthcare. The others are not as bad as mental issues. Our kids are from a different society and we are getting confused. So my question is there a plan for that? Opening a hotline. Thank you.
Yeah, that's a good question.
Okay, so if I understand correctly, are you asking for a hotline that's specific for Eritreans or just in general?
Yeah, if it comes to worse for Eritreans who gets really, you know, need the help. Not everybody, you know, specific.
So, I mean, personally, that's something that our group really doesn't have the capacity because you need to have someone that mans that 24 hours. But there are, in general, I think it's the one that I had on my slide. The number over there, it is a number for anyone, 988. You call anyone when you need help, or if you notice someone who might be hurting themselves, you can call and say, listen, I have a daughter, a neighbor, or whoever, and I'm really worried that they're about to hurt themselves. And they will provide resources either by phone or they would send a 911, they'll send you an ambulance to transport the person to the hospital. So it's a number that is manned 24 hours, 7 days a week. Could be Christmas morning. It doesn't matter what time it is. There's always someone to answer the call.
So if I may add to this, you know, in response to the mental health crisis we've had, there is a designated crisis number that anybody can call or text. And the number is 988. And it's a 24-hour, 7 days a week hotline. Anybody can call, or anybody can call if and when they have concerns about the safety and well-being of someone else. 911 is always available, and I think it's important for people to know the resources they have in their community. Okay? Most counties or cities, they actually have a mental health crisis center. So one can call there, one can go there in extreme situations. You can call 911, go to the emergency room. In the jurisdiction that I live in, just outside of Washington, D.C., Montgomery County, there is what's called a mobile crisis team. The mobile crisis team is available 24 hours a day. Any concerned family member, individual can call them, explain the situation, and they will come and do the assessment in one's home. So there are many resources available. In regards to, having a hotline for the Eritrean community, that will be a little bit tricky because we all have, our day jobs, if you will. We do this as volunteers. We have limited number of people who function in mental health. Maybe there is a need to seek and look for others who participate in different parts of the country, and maybe have better resources in the future. That's maybe something we need to do. But in terms of accessing mental health for emergency services, I think depending on the jurisdiction, depends on where you live. I hate to say this, but some areas and some places have better and more resources than others.
Hi, hello. First, I want to thank you all so much for a very terrific panel. This has been really amazing and informative, and I'm truly grateful to be here to listen to you all, so thank you. I would just like to kind of ask a question about I know we weren't able to get to it, but if you could speak a little bit more to the generational trauma piece, and if we could hear more about what generational trauma is, how it impacts us specifically as Eritreans, and how it can show up. And then also I kind of wanted to hear a little bit more, and it could be from either one of you all, how drugs and alcohol addiction can play a role in all of these mental health issues that you just explained, and how that also impacts our community, and especially our young folks. So thank you.
Well, that was an excellent question, but it depends on how much time we have today, okay? So, to very briefly touch on generational trauma. I have a slide up there, I don't know if you can read it. So generational trauma is the passing down of traumatic experiences or stressors from one generation to another, okay? So this trauma can be transmitted within a family, within a community of people who've survived traumas. And when we speak about trauma, there are so many different types of trauma, so one cannot or should not be thinking only the major types of trauma. Of course, wars, internal displacements, famine, poverty, or even on a larger scale, people who've gone through unfortunate generational traumas of slavery or survivors of genocide are all, victims of traumas. So it's passed on from one generation to another in different ways. One of the forms is actually genetic transmission, meaning a traumatic experience can bring about a change on the genetic makeup of an individual. The person's DNA can potentially change, and in the medical community we call it epigenesis. So the change of the genetic makeup can bring about a change in their offspring, their children or second or third generation may be predisposed or have a higher risk factor for depression or anxiety. This is purely biology. The second one is cultural transmission. So that is passed through stories, through traditions and beliefs. So if different communities develop certain level of animosity or negative feelings, hatred towards another community, this is part of how generational trauma is passed. People, from way back to survive aggression, they moved up to hilltops to live. And living in places like that, they do develop certain, level of alertness, awareness to survive. So certain things are transmitted through cultures. And there's also, unfortunately, a direct exposure to trauma. Trauma survivors, unless they recognize, they manage, and they get help for their traumas, unfortunately would end up being perpetrators, meaning they will be the ones also to have a higher risk of inflicting trauma to others. So domestic violence, growing up in a chaotic and unsafe home, children may have an exposure to trauma as well. So that's unfortunate. That's part of why there is a need for this type of open conversations in our community. Even within our medical community, we were having a conversation as to what topic to present to our community, and there were some thoughts that, oh no, this doesn't exist in our community. The truth be said, it does. The only difference is we don't talk about it. And certain behaviors, certain ways of relating to each other, unfortunately, are a result of trauma. And there's also learned behavior. Some parents pass on unhealthy coping and behavior. In Tigrinya we call it Harkan, Batri. We're modeling behavior to our children. So some of it is unrecognized trauma that's passing on and being modeled. There's a slide so I left this slide purposely early on, and I'm going to read it because I think it's very important. Even though this is for all of us, including me, even though you cannot turn the clock and erase the trauma you have experienced, you can try to prevent it from being passed down to subsequent generations, starting from your own children. So prevention is the effective way of intervention. Recognize the trauma. What was your trauma? And how it may have impacted you. Build resilience despite the trauma. Learn how to cope. Learn how to solve problems. Learn how to behave in a more adaptive way. You brought up alcoholism. A lot of people resort to alcohol and other mood-altering substances because it will numb them for the moment. But when the effect of the alcohol or any other mood-altering substance wears off, the problem is bigger. And unfortunately, it also increases their impulsivity, their anger, and their mood dysregulation. And finally, I would like to say, therapy can be helpful in thinking more positively about self, change behavior, develop better coping skills, and improve relationships. So all this is what we call trauma-informed treatment or therapy. I hope I answered your question.
We will have time for one more question from the group, and I will let you.
Hello. سمي مسكتنا بعض. كل حضرتك عارفونا. كلكم بتاعنا مسلم. كلتا طلعوا تعال تحطه اسمع باللغة. تعال تحطه. مستي كل مستدلو كلتات خيدة كونتن خيدة أبزق قدام فستيفال سنورت حنتي ناي سونوغرام نعواتنا نديهاتنا تقرقل بحدش درجة كتقصة دواهيرو فاتنا يرمو وتحرطوش تحرطوكم ترجع خيدة حابري كان ترليكم أبقى عم تاي درجة بسيحة تقرزيها أبقى بلود بسيحة هذا كسر الطوي ورتعاو الطوي يسوقها ودي تبقسي ودي وتربع خير عمل تخونه استخبارنا ترانو يعني ساقة اللغة هاي أما جمرتو تي دياغلوس مسخونه من هاي تأزلو مش جمرو دحان تصنعوه حاول يدفعوه زيهم كيوزلكم لو تاريخي وين يقول بخماي حاجة استراتيجي كابتن نقول ناخذ مسي استراتيجي هذا عرفته كابس دراجت عمتها على تمر غول مفلاج جميل نبي نتنسيه سايكاتريست لو مدهاني وصدو كبدت دوسخ قال مدهاني نيرو I was donated to Abi العلمو صادق حجي كنت وصلنا له مدهاني لو تعيني سلازي بقربة وصل لي دكتور محتمي الدر رقيبة كزاربك كادت التغيري زولة صنير موري كزيت يوصلكم عندي اللي بتاعنا هذا لوزدلي عبدي يقول لنا تاي حانت سويتي يا أمرات فيها راح نفسها بربور أبغى تزوج الدنيا أنت أكثر ما يرتان يوتيوب أنت حقيقة بس كل قاس حالفنا من دستوقينا من ساعدنا نحوارنا كنت صار أخيرهم سيريهم تقيمهم ومزقين مزلهم سلسلهم عارف أقايمهم تبغى تهاكم تبغى يدقشوا
No.
Yep, for the first question, I actually don't know the answer. I think it was ultrasound fundraising. That wasn't our group. I'm not sure which group it was, but we can have maybe the festival committee answer the question. That was a separate group from us, but yeah.
Okay. Welcome to Ababa Zwoloto, Dr. Ababa. نايثاحتو ملسليبلنا دحراب زي زملكتهم أكال الله وينهم نتعمل سابنا تاحل أي ثحتو بالزحبة ودقوم استزاربكم ومالت فيو سكيزوفرينيا زلو مو كنت من عالباش نسقهم بحالهم زحالفكم مو تحفو سنة أمروز أقامين نسقها عدمي جمرهم كله أنا عشر كعسرة عسران حدن عسران كان عميته وتاجز جمر ندحر كورب دنجيو جميرو جناب لك نستيو دنجيو جمر دنجيو سلاز جمر سقابتز جمر لن سقابتز جمرو وانجن بزح تماهرانيان أتشيف ديرانيان experience على سوتات تكم It is schizophrenia. I'm just going to go. أنا حسابات أجابي زي مقبال زي ملزخونة. حسابون لك عيكون. It's off. No أنا كنت أجامي بالليل. أنا دحاني وتسقطكم يوم سأجام زلكم زبل الرعاية زرباس زلوي. أنا حجي. إتي أفاوس ببجزيون ده تغير مسيرنا. أنا إتي كجمر كله training تسعات مالتي early 90s زنبرة فاوس حجي نتقوم لونين أبز عدي أبكاله of course unfortunately استلالو بزح side effect هالو okay أنا حجي أب state hospital as part of my training سرحني ر state hospital كبال كله ثم أب community حكم وزيك بسبات أو أتيوم أو أروح أمتات فهم حلو زي ما تجيب أجيت forces وشتوز نبرة بزح side effects لز نبرة ثم حمومات بتلوانة ما حد شجار عندك خنير إتزت كخلو مغنيات of course stress يرنا قليل يوم قلنا تشجار عن medication نتفوزي metabolism كلتي هو يخاف system هم زوج أونير okay زعدي ده حارينا نفوت so soon I كلام زنبرة فاوسي ده حد second generation زبها لا فاوس كاب كل تشح جميرو مزيو مالتي atypical لهم كابتن ايك ادم مستفلي atypical antipsychotics neuroleptics نالباش ودهم فتيلون تنيرو olanzapine وزيتركسا risperidone quetiapine سيركون زبالو وفاوس مزيو ات target النيوروreceptor سرحلو كابتن ايك ادم زنبر استفلي قاليو يسرحيو بزبزح يسرح تسقم side effect it is was to foresee net target kokka kollo abkad parts of the brain is go side effect aji abkad on another part of the brain it enhances the appetite it show hatom lali zghayr bali amal shafuniyo so kibdet malsa diabetes malsa aji nisutat net compliance net force mustat agam filter daga has واحد كونكولو تفوسي لموستو صباحي وستو صغمي اجي جن سالساي جنريشن newer generations بحالا فاوس مزيان الله تارجت كورك يريلي كنت هال اي generations never effective icon and less side effect الله الحدش مسيوز الله فاوس injectable يزوق قاعد بغلتها سومون بربعتها سومون بغلتها ورحي بشدش تورح كمان زوق عفاوس الله so مستوى ابتسيستمو مساعتوا over time release the whole malady لازو اسكايدو اي وسر كايدو الكاباسي اي هلون مالتي لذي النحر ابوتات من الباشوال عدل ترغيبنا مسود انا خزاركم نخيس قبل يلن ግን ለውጥታት አለው እንደተማሐይሽ ኸይዳለው እንደገና አምስቲ አፋውስ ሰፖርቲቭ ቴራፒዝ ባህላለው ሳይኮ ኤጁኬሽን ባህላለው ሜገር ካስትነቱም ወልቀሰባት ራህ ደኮነስትነቱም ቤተሰብ ወራነት ኮሚኒቲስ ከሜገር ካቱም ህረው ኢንሰንቲቭ ትገብር ከከምት ትኖረሉ ሶሳይቲ ፍለዩ and support groups كمان على ناميز بحال على National Association of Mental Illness سرعة training هو بيوم شو درابيت نولد غنوز مسؤولو سلازي سلاس باقبر بسرع فوس رخيبو tolerate قبرو فوس رخيبو compliant كوينو ببقيزيو اندخلن لا توقع دا هيوتو بحاقمو خمرح تستاقب.
Thank you. So due to time, we do have to wrap up our seminar. I just want to say thank you for everybody for attending. Thank you to our wonderful panelists, all the work that they put in to prepare. If you did not get a brochure yet, a brochure for our organization is at the front. It has our information. There's also a QR code to stay in contact with us. You can enter your name and email address, and we will send you updates about future events that we will have. I know there's other discussions surrounding mental health that you all want to discuss, but we will do more topics. We could talk about mental health more in the future. Our organization does put on webinars over Zoom, so anybody in the U.S. can attend, and we'll have our panelists there too. So to wrap up, we're going to have our EAMA member, Dr. Mike, give a comment, and then Dr. will also.
سلام وعبد الحنان صاحب يغنى لاي تعنا ثم هارون زمتهم مجمرة مزوج صوتنا مزجورا فاترون جزيهم كثيرا حدثنا نحن نجري لهم زمتهم حافشة زي لو ما عاد استمرنا بزعبنا حنقول تمام لمية كروسو لمية أكثر تركب مالتي تي أرزعت تحرينا حجي أبا أمريكا مالتي 4 نتحبوش تريليون يوم تكون الحكمنا مالتي تشحن 3 كاري تجمعتهم وزنو شو عطنا نتحبوش تريليون بتسجل لازم إذا عاد حكمنا فراكشر يبغى ولا خير مالتي دحر الكوفيد كان دحرينا تخلتي طلب حكمنا زلو ناي مينتال هيلث بس طلب زلو نا سايكايتريست كاين واي اكسس ناي ثيرابي واي ሳይኮቴራፒ درجة شديد شهر عيش شمال نوع زي توصل. هجري إذا كنت ساعات حيلات أستمرون هنا من تان تحرر سرنا ناخذ مهار من تان كفاميلي ككوميونيتي تما هي ناس بعدنا بكتانا نقبرون نجارات زحق زي مالتي أبزي زوم صوتنا أستمرون يبغى مالو بتناتنا محبر كاري أب أونلاين مالتي تمزي دكتور آغاز مالتو بزوم هذا استفعل عليه من قدرات استفعل عليه أستوبرون مع حبر السرنا ناتنا ببقى زين هبينا أو بتستعطفوا كتصار استوبرون قبله مزي أرجعتي مزلو ناي حكمنا حربوت كوتار زحدي نحن خم فاميلي كم كوميونيتي كم حبر السر كم يجينا بعدنا هم قبرون نجارات أبجزانا أب كوميونيتي معنا نقبرون تبلا مبتو مالتيو لازم نتعاون يعني لنا كم زغت سال اقتصاد وما تسفل
مرحبا عليكم مجمرة نحضر حكاين إرتراوين أمريكاوين نزي كم زعينة مدد كبابش لشجعات ورحي جزي وسيلهم نزي مدد نزول دولنا باش نقولكم كمسكنوا مدلي እቶም ተሳተፍቲ ከዓ ግዜ ክፍልኩም ኣብ ስለዝመጣኹም ከመስግነኩም ምደሊ እታ መልእኽቲ ከነሕልፋ ዘለና ግን ማሕበር ኤርትራውያን ኣሜሪካውያን ኣብ ኣሜሪካ ናይ ሓካይም ማለት እዩ እቶም ሜዲካል ፕሮፌሽናልስ ኩልኩም ኣብዚ ማሕበር እዚ ጆይን ክትገብርዎ ኣባላትኩም ኮንኩም ዜጋታትኩም ከተድሕኑ ኣብዚ ኣብ ሃገር ከዓ ሓገዝ ኣብ ዘድልየሉ ግዜ ምስኣቶም ኮንኩም ክትሕግዙ ምእንቲ ኩልኩም ንስኻትኩም ጥራይ ዘይኮነ እቶም ኣብዚ ዘየለዉ ኣብ ሜዲካል ሞያ ዘለዉ كلاتهم كساتهم بس قدام زي حبركم مدلي لازم مدد زودونا كقرب الناس أني يسموها عنا كأني دكتور باهكي فلزدي دكتور ملهاني مهتمة سلاسة روزينا أبراهام داوود جبر مجهن دكتور إدل تحاوس دكتور سلام جبر ندريس دكتور فالن دمساس دكتور أرون كفلا دكتور ميكيل سلومون دكتور أبابا برهاني بزايتي وتعتصفيكا كلكم نزي أسجدت تعب صار كلكم نزي ندرس نزدقكم لنا نذكركم كل خاتكم كا أبسيج دوكتور لها بخبري يعلمكم بزايت أبيام كا أو هذه نزي ندر يغنينا دكتور هيدا مزقبل دكتور سلام مركا Among Eritrean American medical professionals, وكيلة president نايت محبر بزيتي أبابا دكتور أبابا قبلنا. كلهم أبنت كابزم بطلنا كتوزي لابو كلاتهم يرتكيتهم بعلهم كفيلهم نزل مدد بجنزبهم هوتيلهم كل نجر بعلهم كابر جيرهم بولنتاين نزل مدد زجورو زلهم كل جزء إرتراوين موياوين كان تعين سوسيدهم سرقة كل مختن دلي لكن لنا كلهم حكاينا في إلى كان